Good evening and welcome back to the State of Black Health for 2024 here at blackdoctor.org. I am your host, Dr. Renee, and hopefully you've been watching from the beginning, but if you haven't and you're just watching the replay, you can go back and watch. We've talked about obesity, we've talked about caregiving, we've talked about chronic conditions. This one is a great one. You need to get your pencil and paper or the notes in your phone, and you need to take notes because we're talking about screening. So we are going to talk about screenings for Black men, Black women. What ages, which ones that you need to make sure you have so you can make sure that you stay healthy for you and your family. So please, right now, share the broadcast to whomever. You can also let us know where you're watching. Put it in the chat. If you have questions about anything, please put it in the chat and I'll try to check it out and get those questions answered for you. But please make sure you share this because inevitably somebody is going to need this information. I promise they will. So please make sure that you share this information and we will bring on our guests. So we have Dr. Dara King and Dr. Joseph Kay. So Dr. King, can you please introduce yourself? Uh-oh, is she frozen?
Yeah, hi.
Oh, there she is.
Can you hear me? Yeah, okay.
Yep.
Happy to meet you all. Can you hear me?
Yes.
Okay, awesome. I'm Dr. Dara King. I am an OBGYN. I have been working for over 20 years with women's health, and I have my own show, Girl Talk with Dr. King. We can talk about that later, but I'm really happy to be here and happy to share this information with you all. So thank you for having me.
Hello, everybody. My name is Dr. Joseph Okway. I'm a urologist. I'm practicing out of Douglasville, Georgia, and run kind of a primary urology practice. Been practicing for about 3 years now. I also have a social media following and just like to talk about health with a humorous spin. And we can talk about that later as well, but my handle is
Thank you. Okay, so let's get right into it. Let's start with ladies first, of course. So, Dr. King, can you please start with, let's start with adolescence. You know, even before you're actually a woman, quote unquote woman, adolescence, what screenings do they need to go to, like particularly before they go to college?
Okay, so it's really important to know your patient. So I like to see patients, I like to ask their history. I think the most controversial topic is the pap smear. So when do we get a pap smear? And, you know, our guidelines have changed over time. And this is the shocker. We start pap smears at age 21, whether the patient is sexually active or not. And that's not how we were trained. And that's not how I was brought up. So age 21 is when you start having pap smears. And that does not mean that I don't want to see them before 21. That just means that's when we'll do the pap smear. You need to understand that a pelvic exam is the main exam, but the pap smear is only part of it. And that can be confusing for patients. So if I have a 16-year-old who's sexually active, I definitely want her to come in. We're going to do screening for sexually transmitted diseases. I'm going to check out her outer anatomy, her inner anatomy. We're going to talk about her periods. We're going to talk about all the things. We just won't do the pap. So do you understand what I mean when it gets confusing? Because patients want to tell you like, oh, well, I think I need a pap. Not yet. So for my teenagers, I like to always get, even if they're not sexually active, I would like to see them around 15, 16, mainly because they need to have a familiarity. They need to know that this is not taboo. Sometimes I may just talk to them the whole time and not examine them. I think it becomes a uncomfortable thing if the first time you're on your way to college and your mom says, hey, by the way, go see this doctor. We need to establish care and establish a relationship. So for my teeny boppers, just to recap, if they're not sexually active, I still would like to see them around 15, 16 years old. If they are sexually active, as soon as they start to have intercourse, they need to come see me. But the first pap smear, not until age 21.
Okay, so I have a question then. So if you have a pap smear till 21, what about cervical cancer screenings?
I'm glad you said that. So let's talk about what the purpose of the pap smear is. The purpose of the pap smear is to screen for cervical cancer. cancer. There's two reasons why we don't do it under the age of 21. One is the risk of cervical cancer in a patient under the age of 21 is low. Also, we know that HPV is the cause of 99% of cervical cancers, which is what we're looking for when we do Pap smears. Young people tend to clear that infection out of their body. So what we were doing, when we were doing testing on these women who were under the age of 21, and we were doing invasive things on them, knowing they would clear it regardless. So I don't know if you remember this, but we used to do certain procedures. It's called a leak procedure. It was cutting
Mm-hmm.
cervix. We don't do that on, well, I'm not going to say we're not going to do that, but we were doing it on far too many women, increasing their risk of preterm labor, preterm birth, short cervix, and they were clearing the infection. So, out of evidence based medicine, and this has been for some time now, we don't do it. So, screening for cervical cancer under the age of 21, we no longer do.
See, I learned something today, you guys. Wow. Who
Yeah.
knew?
Yeah.
Okay, so Dr. Akwe. So what age do you want? Do you do teens as well? Unmute, unmute.
So teens are an interesting population in neurology because typically I see the older men, right? You know, typically men start seeing neurologists at age 50. Now, that being said, when would I see teens? In two particular scenarios. So, of course, STD, STI testing, and testicular cancer. I'd say those are by far the most common scenarios where I'll see teens. So I always stress to folks, even teenagers as young as 13, 14, 15, testicular self exam is something that we stress. And of course, if there's any abnormalities, we encourage patients to come see us. Uh, at the same token, if a teenager is going to be sexually active, they should definitely be knowing their status and being responsible in that regard. So those are scenarios. It's not a formal screening recommendation, you know, outside of the general screening, usually at 18 for things like cholesterol and blood pressure. But urology specific, I'd say those are two scenarios where there is some sort of screening, whether it's dictated by the patient with a self exam or dictated by the patient's particular experience and potential exposure to STIs. And that's when I definitely have them come see me and, you know, be forthcoming about what's going on so we don't miss something potentially serious.
So who would actually who would teach a child how to do testicular cancer screening? Like, you know, what I mean, is mom and dad to do that? Because you just said that they don't come to the pediatricians do that.
Yeah, a lot of pediatricians who are seeing teenagers, they definitely it should be discussed. And, you know, patients will typically have those exams, hopefully with the pediatrician one-on-one. And yeah, definitely. So it's one of the things that they discuss routinely. So patients are pretty comfortable with it when they do come see me. And if there's any abnormalities, they can say, yeah, you notice, you know, I do it every so often in the shower, but now I noticed it was a little different.
Okay, just
So
like
I
what?
have a
Yeah,
I
screening.
have a 13-year-old son, and it's pretty interesting times. Okay, so he has a female pediatrician, and so they have conversations about, you know, his body and his penis, and we're real big about not naming it something other than what it is. Um, but it's difficult as a parent and as a mother. Like, I don't want to see your penis. Like, I don't want to check it. And I hope that she can check it for you. And one time, and you know, he's going to be embarrassed me putting his business out, but this was about 3 years ago. And he was like, I think, you know, there's something wrong. I said, yeah, talk to your dad. He was like, but you're a doctor. I'm like, but I'm not your doctor. So, you know, those are conversations that you do have to have. I mean, I am a female and you know, I do all the female things, but I talked to my pediatrician. So I'm glad you brought that up. I talked to my pediatrician about how to talk to my son about these things because they're starting to understand body image and body privacy and 13 and, you know, all the hormones. And so now he's at the point where I don't think he wants me to be in his business like that. But, you know, and I have a 19-year-old son. So we went through that same thing.
Yeah, I think to your point, it's important to have that dialogue. We colloquially refer to it as the birds and the bees, but there's much more in terms of the conversation of sexual health and your own body, and those type of discussions that typically wouldn't happen, but they have to happen at some point, and you just
Yeah.
find a way to facilitate that, and explain why we do these things.
Yeah.
Yeah.
I agree.
Yeah. So, I mean, well, look, kudos to him for saying, I think something's wrong, because that means he's paying attention. Because that's, like I said, that moves into the whole breast cancer thing. If you
Yes.
don't check your breast, then that one time a year that your doctor checks them may or may not be able to figure out that something is different.
Yeah.
So,
So, we talk about self breast awareness. We used to talk about self breast exams, and we used to say, and how I was raised was to do it once a month, right around your period, that kind of thing. We kind of shied away from that, but we want you to do breast exams or self breast awareness so you're familiar with your breast. And a lot of times it's the spouse or the partner who can feel a lesion, or they are closer to their breast than I am, because I only see them once a year. And screening starts for breast cancer at age 40. Now, I just gave a talk about a couple of weeks ago, and I had a quiz up, and I had 40, 45, 50, 55, and the majority got it right at age 40. But you do know that certain institutions support certain times to do it. So for an OBGYN, we follow the American College of Obstetrics and Gynecology. We say 40 and every year from there. Sometimes you'll see people say every other year, and that becomes sticky, because if they don't get into the routine of getting it, then it starts to be every 2 to 3 years. Oh, by the way, when was the last time I had my mammogram? So if you know that you're seeing your gynecologist once a year, which you should, then we're getting our screening at age 40 and every year from there. Now, the difference is, of course, if you have risk factors or family history or personal history of breast cancer, your screening would be higher, but that's a whole different story.
so my doctor, I actually had a baseline at 36.
Mm-hmm.
And I didn't have family history or anything, but she was like, you should go. And I was like, I have 4 years until I have to wait for this foolishness. And I had this whole just fantasy in my head that technology would improve and I wouldn't have to squeeze my boob in that machine. And that was my thought. And I was like, so I got 4 years more for technology to improve.
Yeah.
Please just go get this done. And so I did. And it was no big deal. I was like, oh, no big deal. Okay, great. She goes, yeah, now just go back at 40. Okay, great. So I go at 40 and they found something. When I tell you.
At 40.
I was just like, no, Jesus, no.
Mm-hmm. Mm-hmm.
The hospital was literally down the street from my house. So it was 5 blocks, if that. I got into a lift and called my mom. My mother is a retired priest. I said and my mother is a worrier too, but she got on the main line and I needed his help. They found something. She was like, what? I said, they found something. She's like, oh, what do you have to do? And I said, the lady said that I can come in tomorrow for the biopsy. So what happened was I went and had it done, and then they called less than 24 hours later. I was actually at CNN when they called.
Yes.
And I was like, this isn't good. Why are they calling me?
Why are they calling me? Right.
I mean, and it might have been the same day, because I had an early morning appointment and then the flight. So I think it was the same day. It was that afternoon they called. And so I was nervous, Nelly. I called back and I left a message. She didn't call me back. So then I called again, and the person answered who had left the message. She had a thick accent, so I knew it was her. So I said, this is Dr. Renee Matthews. You called me. What do you know? Oh, we need to schedule to come back in. Why? Oh, no, ma'am. Dr. Renee Matthews. I am a doctor. You can just tell me. Just tell me what it is. Yeah. She was like, it was incomplete. Now, mind you, I was with my clients who were 2 OBGYNs. They're twin docs, and the twin docs are male. And they were like, oh, Renee, people our age, that happens all the time. And I said, oh, okay. So they had put me, I'm good now. Had a great trip in Atlanta. I go back to Chicago for this appointment the following week, and I go in there because it's incomplete, right? I go in there, I'm just good, and then the lady is like digging into my breast, like
it's right up in here.
yes.
Yes.
And so I don't say anything, and then she goes, "I'm so sorry, but it's way back here, so that's it." And goes, so she looks at me and says, "They didn't tell you they found something, did they?" I said, "No."
Mm-hmm. Mm-hmm.
And at that point, I was just like, oh my God. So then I think she saw in my face that this is a problem, and she goes, "You'll know before you leave here today." I said, "Oh, okay, thank you." Mm-hmm. So she finishes, I go and sit, and the lady who comes to tell me, the nurse, she has the cheeriest smile on her face. I go, "Oh, thank you, Jesus, I'm going to be okay." This lady comes, "Okay, so there is something there. We need to do a biopsy." I was like, oh my God, that was not what I thought she was about to say.
Right. I wasn't waiting. I wasn't ready. I'm like, okay.
It's not happening. So then she goes, "The good news is we have an appointment available tomorrow at 12:30. I said, "I'll take it." And so, like I said, I called my mom in the car and told her, and she goes, "Well, your aunt had what did she say? Had cysts or something." And I said, "No, I didn't know that." And she's like, "Yeah, so maybe that's just what it is." I said, "Lord, let it be, because I cannot." And mind you, this is the same hospital. No, because it was so small. Okay. This is the same hospital my girlfriend that created Thank God It's Natural TGIN, Christia Donaldson, may she rest in peace. This is the same one that diagnosed her. So she, the second call I made, she was like, "You're gonna be okay, but if they find something, you need to switch care to someplace else, because that's just not gonna work." I'm like, okay. And she goes, "You just let me know." So I had the biopsy done. That was the most miserable process. Have you ever been blessed?
I've never had a biopsy.
So my arm was like this, and I was laying down for it was more than an hour, and I couldn't move, and my breast was in this hole through a table. Yeah. The doctor was underneath the table. I took a picture and sent it to my sister before I started. My sister goes, "Does your boob go in that hole?" I said, "Mm-hmm." It was awful. And
the way technology is now, you just drop it on down.
I was like, this is the great. And then, I would have to hold my breath, and they do another, mammogram. It was just crazy. So this was right before Memorial Day weekend. He said, "I will have the results by Friday before the Memorial Day weekend." Okay. So then, of course, my mother's calling me on Friday. Like, "Have they called?" I'm like, "No, Mom, I will let you know." "Well, you better call them." "Oh, Mom, just calm down." So finally the lady calls, and she says, "I have good news. You can enjoy your weekend." It was nothing, but they put a marker there. So whenever you have a mammogram, they'll see it. They'll know that that's where it was, but they did it. I'm like, okay, thank you. I was just like,
but Lord, that's the whole purpose. That's
yes.
It should be streamlined. It should be, I see something, let me make sure that it is what it is. Let me get a biopsy. Let me send you on your way. Sometimes we have so much, especially with health equity, so much delay in care.
Right.
That I think the way that they pushed you through, and also you were an advocate for yourself. And that's what we really need to talk about when we talk about this screening process.
Exactly.
How can we better speak up? You're Dr. Renee Matthews.
Right. That's why this is important. This conversation is important, because if you don't know what screenings you should have, then you don't know what the doctor may or may not have forgotten.
Right.
Or you and I, we all know that there are things that people are learning today in med school that 20 years ago they didn't learn. So therefore, they don't even realize that things have changed, and now you need to screen for this at this age. And so that's why I think this conversation is important. So back to Dr. Say your last name one more time, sir. Acquay. That's it. Acquay. Okay, take yourself off mute, but I want you to talk about what screenings do men need to have in their 20s? So say they're college age, and they, most of them don't go to the doctor like they should, but what should they be doing?
Well, again, with men in their 20s, in general, the only screening that's routinely recommended that early is cholesterol screening, especially if you have some family history. And then, an annual physical every 3 years or so is usually recommended once you hit there. And then, of course, universities are going to have preliminary STI testing in some cases. But of course, that depends on potential exposure and things like that. But aside from that, from a urologic perspective, again, about the same, particular self exam and testing as indicated for STIs. I mean, for men, the fortunate thing is they typically don't need to see me for a little while.
Right.
Then suddenly they have to see me all the time.
Right. Right.
Right.
So, Dr. King, in the 20s, what testing, what screening should ladies be going through?
So in your 20s, definitely if they're sexually active, like we talked about STDs, STIs, we have to start thinking about people. What we don't plan for is pregnancy, right? But a lot of times, people get pregnant when they weren't planning to get pregnant. So it's really good to do those labs before. So if you have sickle cell trait or sickle cell anemia, if we're screening for rubella, we're screening for, so we should have a baseline of labs just screening for those things in case you need to get a vaccination and all those things. A lot of times they come to us as their primary care physician, which I truly believe you should have a primary care physician at OBGYN, and most don't. So we will be screening. You're raising your hand? Okay. No judgment. No judgment. But so a lot of times we do the family history, just like Dr. Okoye said, and we will be screening for your cholesterol. We'll be looking at the thyroid. We will be doing those things too that are generally typically done with your primary care. And we do that in their 20s. Also in our 20s, and not in terms of screening, but we start talking about vitamin D and calcium. We talk about birth control and all of those things, but we want to start protecting our bones earlier. So when we get to one of my last screenings, the bone density, we're not necessarily increasing our risk of osteoporosis, but we'll come to that as we go down the line.
Gotcha. So in the 30s, I think some men might have to be doing prostate screenings because their family history, correct?
Yeah, I'd say it's, especially obviously, we generally use a 10-year rule. And I've definitely diagnosed prostate cancer in some like late 30, early 40-year-olds, particularly people with the family history. So it's not routine, definitely for men, but yeah, it's definitely a possibility. I think just like with screening in general, you really have to tailor it to the individualized person, and you can't really just go off the broad recommendations anymore. So we definitely employ that when necessary or when appropriate.
And what age do they start doing the digital rectal exams for prostate?
So honestly, the digital rectal exam has fallen out of favor compared to how
Really?
how much it used to be employed. Part of the reason is, of course, it lends to a lot of the anxiety with visits. And honestly, we've shown that people will avoid visits to avoid the digital rectal exam. So I always preface my visit with, hey, we're not going to do the exam today. Now, that doesn't mean I don't do the exam at all, but typically the exam would be reserved for somebody who's having a biopsy, who is already under some sedation or positioned in a better way than the typical, hey, bend over so I can do your exam. That way you get a better exam, and it's in the context of subsequent biopsy. And also, you don't want to do an exam and potentially irritate the prostate or artificially elevate their labs, which we use in screening, as we'll talk about. So again, I don't do it as much, and I think a lot of patients, it does help a little bit with compliance here and there.
Got it. Okay, so in the 30s, what are we doing with the ladies?
Yeah. So that's a big change. That's a good age where we start testing for our pap smears with HPV together. Okay. And so we talked a little bit about it. HPV is human papilloma virus. So it is a virus that could potentially cause cancer. It doesn't always cause cancer. Sometimes it could cause something called genital warts. There's many different types out there, but HPV with your pap smear is the recommendation. And the reason is we're getting older. So we're not less than, 21, and we're not 21 to 29. So we fit into a different category. And we realize that if your HPV is negative and you have a normal pap smear, then you're doing well in terms of your risk factors for cervical cancer. So that's where we start. We start there. There's times where people, and we get every scenario. So of course you tailor the treatment to the patient. What if my pap is normal, HPV is positive? What if HPV is negative and my pap smear shows this? So those are conversations that you need to have with your doctor. And I don't want patients to have to memorize it. We have to memorize it. We're tested on it. Just come see me and then I'll tell you what we're doing. But at that point, we're doing co-testing, and that's what we call it, HPV with your pap smear. And again, that's just a small part of the big pelvic exam, in addition to all the other things. Of course, if you're sexually active, every topic is on STD screening, and we know why. So when you talk to Dr. Okoye or talk to me, I don't care if you're 14 having sex or you're 45 having sex, you're going to get STD screening. So we definitely do that in the 30s. There are patients who are married, and I'm very sensitive to that. If you don't want testing, I'm not going to force it, but if you do, I'm going to definitely do it. Some people say, I just want to make sure I'm good. I'm not my spouse, but I'm your patient and I want that. So that's fine. Don't ever feel like you can't open up that opportunity for those things. So we do that too. And again, I'm always encouraging them to recover it, but sometimes they don't. So I'm reiterating certain things in terms of feasibility. What are we going to do for that? And then we'll see.
So in the 40s, Dr. Okoye, are they coming to you yet now?
Yeah, so this is where it starts. And usually the impetus to see the urologist, and actually, if you look at the research, the reason why a lot of men initially interface with the healthcare system is urinary problems. That's when your prostate starts getting bigger. That's when you start noticing the slowing of stream, and I gotta wake up in the night, and I can't drive to the grocery store without having to stop somewhere first. So that's kind of where we're able to interface with these patients first. In a lot of situations, I'm the first time they've seen a doctor. So you really have to start helping them navigate the overall screening. Right? I'm a urologist. My training is not primary care, but certainly I end up having to coordinate. Okay, you probably should see the GI, and you probably should see, this and that. But that's when we start. And of course, PSA screening again, or prostate cancer screening, is not necessarily recommended at 40. But of course, if you have a strong family history, we're going to start. And then if it's normal, we may not stick to an annual surveillance schedule until you hit 50. But still, that's definitely a place where we can start things. And then, of course, as you mentioned, it's always going to STI screening is another reason why that age group would interface with me. And then, so those are the main things. But I'd say at that point, of course, if you look at the bigger picture, that's when you're starting with, that's when you're continuing high blood pressure screening and cholesterol screening and risk stratifying for things like abdominal aortic ultrasounds and all of that good stuff. So I definitely have inadvertently had to figure out a lot of the screening things for these patients and get them plugged in with somebody.
Perfect.
I have a question, Dr. Okoye. Tell me about your patient population in your 40s and dealing with infertility. Do you see a lot of referrals from, OBGYN or fertility specialists like, hey, get the semen analysis? Like, is that
so a lot of time, maybe it's like 30s, 40s, but generally speaking, when I do get a fertility consult, it's when, even try, I always say, if you've been trying for 6 months after the age of 35 or a year intentionally before the age of 35, we say, okay, your wife or partner done all the screening or all the fertility workup? And then they say, yep. So I say, okay, we're next. So of course it's 50-50. There's always the onus placed on the woman as the source of infertility, but that's definitely just not true. So for us, it's just a semen analysis. We usually do 2 of them a month apart, and we're able to kind of compare the parameters and see if there's anywhere we can intervene. We look for reversible causes, or in rare cases, things like azospermia where there's no sperm at all, and we got to figure that out. So yeah, definitely there's, I interface with those patients, and then once we figure out if there's a reversible cause, we make the arrangements to address that. And then generally speaking, infertility discussions always center around general health in the first place, because
Yeah.
we know the literature shows that uh, smoking cessation and abstaining from marijuana and being physically active and limiting processed foods and making sure you're getting appropriate vitamins and minerals, these are all things that help sperm health and help fertility. And a lot of times there's not really a clear reversible cause. So you have to focus on the things that you can do to optimize your success.
I was going to say, Dr. King, at what age would you say that a woman should ask for FSH level or AMH level?
That's a controversial topic. So thank you, Dr. Renee, for bringing that up. When people say, I want to get tested for fertility, I always ask them, what have they heard, right? Because technically, you're not infertile until you prove that you're infertile. So there's
Right.
no good time or good test for an FSH or AMH. An AMH, anti-Mullerian hormone, is a newer thing, meaning probably in the past 7 to 10 years, we've kind of been doing it just to kind of be able, and really what fertility specialists, and I'm not one, they really say, we get this to see how well medications would respond to, your eggs will respond to the medication. So that makes it a little bit tricky, because patients think we get it to say, how well are my eggs?
Mm-hmm.
And that we're not using it for that. We're saying, how well would your eggs respond to medications if we needed to stimulate you? So that's a separate topic. When I was in the office, I would usually say to patients, I get the questions, have you started having intercourse unprotected for a year and haven't gotten pregnant? So usually the people who come like that, they're like 27, like, no. I say, well, and you want to meet them where they are. And so I'm always educating at the same time. And again, not trying to judge, but no, ma'am, go out there, try to have some babies, let me know, and I always give them the information, between this day to that day from your period. Every other day, sperm needs time to regenerate. So we have that conversation. When we start to get up in our later 30s, 35 and over, which is considered advanced maternal age, which
Mm-hmm.
recently I heard they're calling it geriatric age,
Mm-hmm.
geriatric pregnancy.
Mm-hmm.
I hate that. So, like, to all the listeners, that's awful and it's offensive. Okay. We use advanced maternal age because I need to be able to communicate with Dr. Okoye, Dr. Matthews about this patient and what may need to be done differently, but not because something's wrong with her. It's just a category she fits in. So let's take that stigma out of that. That just drives me nuts. Sorry. Soapbox. Sorry.
Yeah.
So the so when we start to get into advanced maternal age and we start to see irregular periods and we start to see other things that may give me ideas that fertility might be an issue, is when I would start to have that conversation and do those testing, if that makes sense. So I'm being very general because everybody's fertility journey is different. But if you're normal and healthy and you're out there living your best life and you haven't had unprotected sex for 1 year under the age of 35, we're not really honestly going to have that conversation. When we start talking about perimenopausal, then we can start having that conversation.
So I guess I'm asking for the people who are thinking about freezing their eggs or something, and there's some, because I know before I did anything, they were like, well, what is your, and I was like, I don't know. So then that was a conversation with the OBGYN. Can we test this so that I can then tell her this, and
Okay.
my
So
first
I just had one of my girl talks with a fertility specialist. So perfect timing. I had this with her last week. And I was asking her, I was like, as a generalist, when should I have these conversations with my patients? Right. And so I was like, should we be telling them to do it when they're in college, freeze these eggs? Like, what are we saying? And so she said that women now, we're delaying childbearing for our careers and all the things. Then we get to our 40s, like, dang, I want to have a family. I want to meet Mr. Right or whatever the situations. And sometimes that time has passed. So she said she was like, she feel like the 20s are too early. But around in our early to mid 30s, we should start having that conversation. It just, what are your plans in terms of childbearing? And that we don't talk about enough in the African American community about freezing our eggs. So that's, I'm glad you asked that question. So now I start in my 30s to 35. Okay, so what's your plan? You know, what are you thinking? And now we're finding out, and no offense to the men, but now we're finding out that women aren't waiting for Mr. Right, because Mr. Right may never come. And so we're able to have families on our own. And if I freeze my eggs, then I always have that option, you know. And so she did talk about timing, because at the end of the day, if you freeze your eggs for a long time, they're still going to be long frozen eggs. So you do have to have some type of time. You know, it's not just indefinite. Oh, I'm 32 and I'm gonna save it till I'm 51. Like, you do have to have a plan. And so we had that conversation. So thank you for bringing that question up.
I'm just curious myself, because for men, I do sperm banking sometimes, specifically for testicular cancer cases and chemotherapy, and it's it's not cheap to bank your sperm. Is that the same? It's the same with you in terms of, like, is there a monthly fee, or how does it work?
Oh yeah, it's the same. It's not, well, the freezing part is not that expensive. It's like the equivalent of Starbucks every week, I think, for a month and stuff. So it's like, in the end of the year, I think it's $500 for the year. It's not that, the freezing part. It's getting to the freezing part that's the expensive part.
I see. Okay.
Yeah, that's the 5-figure part. Getting to the freezing, yeah. But once it's frozen, that fee is not. It's not that bad.
Okay.
I think $500 a year comes out to $50 a month, if I'm not mistaken.
Yeah.
Yeah, so it's not that bad. So in your 50s, what are we doing now? Whoever wants to go first.
I'll go first, because we skipped 45.
Sorry. Oh, 45. Excuse me. Okay.
Yes. I don't know if Dr. Okoye, you were going to say the same thing, but
I know what you say. Go ahead. Yep.
Colonoscopy.
Yes.
Okay. So
45, men and women.
Yes, that has changed. Okay. Right. Because it used to just be for Black men and women. We were 45 screening. And then they realized that this should be for everyone. So age 45, we're doing colon cancer screening, and there's many different ways to do it. However, if you do other things besides the colonoscopy, and if those testing are positive, you got to do the colonoscopy anyway. And your friend here, she just did the colonoscopy. I was not about to do any of the other screening tests. I just went at just
2 years ago, I had my colonoscopy, and it just wasn't that big of a deal.
It wasn't that bad. I mean, the prep was like, okay, whatever. But I went to sleep. I woke up. I went home. Like, I wasn't sending in my poop. I wasn't doing that on my own. Like, it just wasn't a thing for me.
So, by the way, Cologuard, that's what it is. You send in your poop, you guys.
Yep, or the fit testing. That's also another test. Cologuard, fit testing. You send in your poop, or you can get it done in the office. Some offices, they'll do the guaiac, where they test it for you. We don't, OBGYNs, we don't do that anymore. We used to, but we just give them the fit kit. So that is something, 45, we need to do it.
And you know what? And we just, in the last one, we just talked about colonoscopies briefly, because one of the doctors, he said his wife, he begged her, please go get this colonoscopy, just go get it. And she got it, and come to find out, she had a walnut-sized cancer that Cologuard would have never found, because she had no blood in her stool.
Yep. So
fit test, none of them would have found this, because there was no blood. But because she had the colonoscopy, they found it. In the colonoscopy, they can take it out.
Yeah. Yeah.
So she didn't have to have chemo, nothing, right? Nothing, because it was found in the colonoscopy, taken care of. And then she, several years now, she can wait to have another colonoscopy. So it's not that bad. And I tell everyone it was the fastest 5 pounds I ever lost.
I love that. I'm going to use that. You're right.
It was. And you know what? When I couldn't eat, I drank bone broth. And I drank it with a spoon like it was soup. You couldn't tell me nothing. It was delicious. I switched it up. I had beef bone broth, and then I had chicken bone broth and turkey.
Right.
It just wasn't that big of a deal. And like you said, you went to sleep, you woke up, it was over.
I went home and it was great.
And oh, the best thing, she gave me the results when I woke up, and she handed them to me, and she sent them to my doctor, and we had a lovely conversation, and boom, done. And she said, "I will see you in 10 years."
Yep. So that's what me. Yeah.
Yeah. So, and I think the other thing is that with colon cancer, one, it's a preventable cancer, and I think people don't realize that it's a preventable cancer. There's not many that are preventable, but colon is one of them. You need to increase your fiber intake. So if you know you eat like crap, please go get a colonoscopy. Because Cologuard is not your friend. And I know the commercials make it look so wonderful, and no, Cologuard's not your friend. You know you eat like crap and you eat processed foods. You need to go and get
you need to go it. Yeah, you're right.
You just need to buy, and honestly, you can request different preps. The doctor that I went to, they specifically said, if that prep is not going to work out for you because of your insurance or you don't like it, then let us know. I had these little bottles of liquid. I just threw them back. It was not that big of a deal. I remember my mother and that Go Lightly. That looked like a nightmare and nothing I wanted to be bothered with. That's the powder you add the water to. No, ma'am. That just looked disgusting. But my little clear liquids was no big deal. Yeah. It was probably magnesium citrate. It was not a big deal. Drank them like I was supposed to. I set an alarm because through the night I had to, make sure I had whatever, because my appointment I had it first thing in the morning. So therefore, I could eat, the whole day. As soon as I got done, I could eat again. But it just wasn't that big of a deal. But it's so important, especially because colon cancer is an avoidable cancer. Fiber is your friend. You have got to either eat it. I drink mine as well as eat mine. There's way too many fiber. They got gummies now. Yeah. There's way too many fiber products. Musil has gummies. And girl, I'm thinking I'm going to check them out just to see what they're like. Yes. But I use Benefiber. Benefiber is tasteless and, it's clear. You put it in your water or whatever you're drinking and you don't know what's in there. And so that's what I do. But yeah, I think I'm going to try the Metamucil. Those psyllium husks were just a little tough. Mm-hmm. Mm-mm. Mm-mm. But the gummies sound like something. And I will tell you, they have cinnamon wafer like crackers. They remind you of Belvita, Metamucil makes. Those are delicious too.
Dip them in milk. No, because it's hard sometimes for people to get fiber in their diet. So
yes.
You just give some really good.
So you got to get it everywhere you can. And these are some other little places you can get it. But colon cancer is a preventable cancer. You please get your fiber. Go have your colonoscopy. If it's an insurance issue, I'm telling you, Google's your best friend. You will find a place. Just like women can go get mammograms for free, you will figure out a place to go get your colonoscopy for free. Mm-hmm. So now we can go to the 50s. We covered 45. There you go. So, Dr. Okoye, 50s, what are the men doing?
So 50s is actually kind of where I probably interface with both men and women on a much more higher basis. So with the men, of course, 50 is the magic age, and that's when most of them will see urologists for the first time, because you're going to start prostate cancer screening. And prostate cancer screening is accomplished through a blood test, a PSA, prostate-specific antigen, which is normally produced by the prostate in low amounts. So when it gets elevated, we kind of get a little concerned. That being said, there are many things that can cause a PSA elevation, including infection, prostatitis, urinary retention. A lot of times the patient just had sex before they got their PSA checked, and it goes sky high. And then I know it's not true. So I tell them, okay, next time just give it a little break before the test, and then we'll try it again. But with that being said, the reason PSA screening is so important is because prostate cancer is virtually asymptomatic. If you have symptoms with prostate cancer and you're coming to see, it's already very far gone, because you shouldn't be having symptoms. It's usually very localized. So, PSA is one part of the picture. And then we have prostate examination, which is another part of the picture. And then these days we employ more and more MRIs, which we use to screen for suspicious lesions. Even though it's not 100%, it's a really good screening tool. But ultimately, the most definitive way you're going to get a diagnosis is a prostate biopsy. So typically, by the time men have seen me, they've had PSA elevation, and it's always important to recognize that you don't just go off one and get very excited. Usually they'll see a PSA elevation, and if it's just a minor elevation, we'll check again. Even if it's a major elevation that doesn't seem to correlate well, we'll check again. But if it shows a steady trend upwards, then you see me, and then we basically plan for what are you going to do? Do you want to check your PSA again? Do you want to go straight to the MRI? Or do we want to biopsy? And patients who elect for biopsy, a biopsy is much less involved in a colonoscopy. So that's how I preface my talk with the patients. At my particular location, we do it under sedation, which a lot of patients appreciate. And it takes all of 10 minutes. It's just an ultrasound probe in the rectum. I'm able to measure the prostate. And then I take 6 samples from the left, 6 samples from the right, and then we're done. Patient doesn't even remember that they had the procedure. And it typically follow up in about 2 weeks because we're not going to get any instant results. We send it to the pathologist and then they give us the results back. And otherwise, there's always a small risk of infection, but, I haven't had one yet, knock on wood. And then there's some bleeding in the blood and the stool that happens afterwards. So nothing major. I tell patients to do it very often. And then once we know what we're dealing with, we know what direction to take. Obviously, there's prostate cancer management is a range from do nothing and watch to, okay, maybe radiation might be a good option.
Mm-hmm.
You're going to need surgery to you need hormone therapy, and we're not going to be able to cure this, but we're going to be able to manage it. But that being said, prostate cancer, for it being the #1 cancer in men, it's third leading cause of death. And it is pretty preventable as long as you're keeping up with screening and, taking care to stay on top of that. And that's why I always stress in general on both sides that knowing your status and family history is very important in that regard. So that's typically a lot of my work with men around that age. And then, of course, I forgot to mention this. This goes anywhere from 30 and up, erectile dysfunction, because erectile dysfunction is a proxy for other problems. People just think, it's not working as well as I used to. Man, my head's not in it. Well, typically it's cardiovascular disease and diabetes, and that's just a manifestation of that. So a lot of times, especially when I have a really young man with erectile dysfunction, I'm like, maybe you should do some additional screening. Get your primary care, make sure you check your cholesterol, make sure you check your blood sugars. And a lot of time, lo and behold, uncontrolled diabetes, high cholesterol, high blood pressure, things that they didn't think had anything to do with erectile dysfunction. But I say it's just a big blood vessel. So I tell patients, and if that one is blocked, there's a strong correlation between coronary artery disease, risk of stroke, risk of peripheral vascular disease, and erectile dysfunction. So it's a very important health proxy, and I think it's definitely in my inadvertent screening tool for a lot of men.
And Dr. King?
So in our 50s, we're still STD screening. We're still doing pap smear with HPV. We're doing our mammograms. We started in our 40s. We're doing our colonoscopies. We started at 45. And now it's my job to start screening for risk factors for osteoporosis. So we know that the average age of menopause is 51. And what does menopause mean? That means that there's 1 full year without periods, and then you're postmenopausal after that. But we also know that hormonally, your estrogen, basically your eggs aren't working, so your estrogen is decreased significantly. Estrogen protects your bones. And so I'm already starting in your 20s telling you to take vitamin D and calcium. We typically don't do bone densities, and the age is 65 unless they have risk factors. Well, guess what? Most women, 50s plus, have risk factors. So you may get a bone density before age 65, and you could, as long as your doctor can tell what those risk factors are, it can be paid by insurance. So what are those risk factors? Low estrogen, that's menopausal.
Mm-hmm.
Smoking, a history of a fracture, history of wrist or hip fracture, history of low body weight. So this is one of those diseases that affect people who are smaller. If you had long-term use to steroids, that can decrease your bone mass. And one thing I think about is my young people who are on Depo-Provera for a very long time. That's a hormone, that's a birth control, that is injectable. That can decrease your bone mass. So sometimes they're getting bone densities.
What's a long time?
You say, what's a long time? So I had a patient who had been on Depo-Provera for 7 years. She came to me on it for 7 years, and I ended up getting the bone density for her. And she was showing some slight, not osteoporosis, but osteopenia, which means low bone mass, but not completely done. And so I started her on vitamin because she did not want to stop Depro. I
I
couldn't force
understand.
her. Yeah, she didn't have a period for 7 years. And that's not everybody's story with Depo. Can you have me back when we talk about birth control? That's another
Yeah,
conversation.
we totally
But,
can.
but,
I was
so
on more
she,
than 7, so.
but it's okay as long as you get a bone density and figure out where you stand. And if you are off of it now,
Mhm.
that bone regenerates. So I think you should be fine. But definitely, if you
And
have
I've
other
been a
risk
vitamin
factors.
D girl for a long time because they did say that I had low vitamin D, and so I take vitamin D with K.
Yeah, but it could have been because of your Depo-Provera. So that would be another reason of getting it before age 65. So in your 50s, we're screening all those same things. And then we're also going to screen for osteoporosis, osteopenia. The things that we didn't talk about screening that I do screen with every visit is domestic violence.
Mm.
I screen for depression. I screen, and that's every visit from however old you are until whatever. I mean, especially when we come in prenatal, and I think sometimes we have to be creative to kind of move the partner away because it's really important to know prenatally if these patients are in a safe environment. Babies and pregnancy can add a whole different thing to a situation. So if we're talking about screening, we screen holistically. But in your 50s, you're getting all that from me. In addition to your cholesterol and your thyroid and all of that stuff, if you don't have a primary care.
So we're getting close to the end of the hour. Is there any other test that you're going to add on? I know you're going to subtract towards 70s, but is there anything you're going to add on the last half of our lives? Either one of you? Are you going to add anything?
I don't think so. Like you said, we will probably subtract, but
Right,
that's case by case
right,
basis because patients are like, when can I start getting a pap smear? When can I
right.
start getting a mammogram? So take that pace by, but I wouldn't necessarily add anything. I mean, I think bone density, if you hadn't gotten one by age 65, that's
That's
when we
what you
would,
need to take?
yeah.
Okay.
Hmm.
Doctor,
Yeah,
okay.
I would agree there. We typically subtract. If you look at the general guidelines, they recommend PSA screening from 50 to 70. That
Got
being said, of course, there's a wide range of 70-year-olds. And if you're the 70-year-old who's as healthy as a 50-year-old, then we have that patient to patient discussion whether you want to continue screening in that regard. But yes, we usually typically subtract, and from there we just kind of, yeah.
Awesome. Thank you guys. This has been awesome. Please, Dr. King, tell people how they can find you and ask more questions.
Yes, so I am on LinkedIn, I'm on Instagram and Facebook, and of course YouTube, Dr. Dara King. And I have a podcast called Girl Talk with Dr. King, and we talk about these very topics. So we talk about screening, and we talk about pap smears and
And
other
your
things.
podcast
So
is on all the platforms?
it's on all the platforms. Yes.
Perfect.
Yeah.
Dr. Quay?
Awesome. You can find me on Instagram. My handle is there, jacademic_MD. You get a combination of humor, but a lot of times it's also talking about some important screening tips and just health in general and topics that people are a little bit nervous to discuss. So we try to keep it light, but also informative.
Well, thank you guys so much for this. We have one more hour for those that have been with us since the beginning. We are talking about mental health. So,
Yes.
and I'm so excited to have this discussion because it is a discussion. Of course, we know that in the Black community is very hush hush. So we're trying to silence the shame and let's talk about mental health. So thank you so much.
Thank
Well,
you.
thank